Hi guys, good evening. Can you all see me? Can you all hear me? Hi guys, good evening, good evening, good evening. So, welcome to another series of BLS. Today we'll be talking about the toxic thyroid swellings. Yesterday we spoke about simple goiter. Today we'll be talking about the toxic thyroid swellings. Walaikum assalam. Hi guys, good evening. So, are you guys ready? Let's kick in. Hi, good evening, Osama. Good evening, guys. Good evening. Thank you. Right. This is for NEET PG, beta. I am a surgeon. I'm Dr. Sandeep, your surgery faculty. Hi, Kurban. So, I hope everybody's tuned up. Okay, so without wasting any further time, let's kickstart the discussion for today. Today we are going to talk about the toxic thyroid swellings, right? So when we see the word toxic, right, the word toxic basically means that it denotes the patient is having a hyperthyroid status. There is a hyperthyroid status, and we're talking about the thyroid swellings. Now, a patient who is having a features of hyperthyroidism, and along with hyperthyroidism, the patient also develops a thyroid swelling. So our objective would be to discuss about these different forms of thyroid swellings. I can differentiate them into three basic categories. One, we'll talk about the diffuse toxic goiter. We'll talk about the diffuse toxic goiter. Then you have the toxic multinodular goiter. Toxic multinodular goiter. Sir, what about the colloid goiter? See, colloid goiter is a variant of multinodular goiter where you have a colloid rich nodules which are formed. See, either you can have a hyperplastic proliferation or you can have a colloid filled proliferation. Either ways, it will result in differential stimulus, and that differential stimulus will result in nodular status. Okay? But it is valid for your MBBS as well as BDS students also. It's a basic general surgery. Yes, BDS students might not require, into a systemic surgery part, but whenever we talk about a general surgery, BDS students are going to be equally benefited from these lectures as well. Okay? Chalo. So we'll be discussing on these three lines. So we have the diffuse toxic goiter. We have the diffuse toxic goiter. Then you have the toxic multinodular goiter. We have the toxic multinodular goiter. And then the last option that we have is going to be about the toxic adenoma. So I'll be discussing about these three disorders so that we can have a sound understanding about the toxic thyroid swellings. Now, when you talk about the diffuse toxic goiter, so our first topic would be of diffuse toxic goiter. So you have a generalized enlargement, and this is going to be in a diffuse form, and it will have the features of hyperthyroidism. So it is called as a diffuse toxic goiter. The diffuse toxic goiter is also going to be named, or it can give you a best example to explain the entire scenario is going to be with the help of Graves' disease. It is going to be the Graves' disease. So when you talk about the Graves' disease, let's understand that what are the components that are going to happen in Graves' disease. Now, Graves' disease, we'll talk about the entire pathophysiology, that how does the gland enlarges, what is going to happen, everything. So the pathophysiology, we'll talk about the pathophysiology of the Graves' disease. So here you need to understand that how is the gland getting enlarged and how is it resulting in hyperthyroid status. That are two objectives that we have. In Graves' disease or diffuse toxic goiter, you need to understand that why is the gland enlarging and why it is becoming hyperthyroid. Itna hi hai, theek hai? So let's try to understand this. So Graves' disease, when you talk about the pathophysiology, it is an autoimmune disorder. It is going to be an autoimmune disorder. So when we say it is autoimmune disorder, all autoimmune conditions will be associated with the development of an antibodies. The antibodies that you can see here, the antibody that is going to develop in the Graves' disease goes by the name as long-acting thyroid stimulating antibody. So you have this abbreviation which is called as LATS, right? So what does LATS means? The LATS stands for long-acting. It means the long-acting thyroid stimulating antibody. It is the long-acting thyroid stimulating antibody, right? So what is going to happen if these antibodies are going to be formed? So you take this as the representation of the thyroid follicle, right? So this is the thyroid follicle and these are the thyroid follicular cells which are present. These are the active follicles. How am I able to tell you these are active follicles? Because you have these cuboidal cells which are going to be present on top of them. Now these follicles will have, each follicle will have a receptor, and this is what we call it as the TSH receptor. This is how a TSH receptor would look like, right? So this is the orientation of the TSH receptor. This is going to be the TSH receptor. This is the TSH receptor that is present. Now we all know that the receptor and the hormone, they work on the principle of the lock and key mechanism. So this TSH receptor that we have found here, so these are your TSH receptors. Now these TSH receptors can only be stimulated by TSH hormone. Now let's say this is the TSH hormone that is produced here. So this is the TSH hormone that is produced. So this is the TSH hormone that is present here. Usually the TSH hormone will go and bind to the TSH receptor. When it binds to TSH receptor, it is going to activate the thyroid follicles and those follicles will release T3, T4. That is the basic objective that is being followed across here. Now those patients who are going to have a Graves' disease, they also form the antibodies which are called as LATs. So these are your LATs antibodies. So these are your LATs antibodies. So when you look at these antibodies, their configuration also looks like the TSH hormone, and when they compete for the TSH receptor, they are more aggressive, right? Now because they are more aggressive, or I can say they're more active than your hormone, these antibodies will now readily go and bind to the TSH receptor. Now they'll go and bind to the TSH receptor. Now problem here is, the minute they bind to the TSH receptor, your TSH receptor thinks that it is a TSH hormone because the configuration is same. It is like the lock and key, no? So as I told you कि ताला चाहे असली चाबी से खुले या चोर वाली चाबी से खुले, ठीक है, चाबी से खुलना इंपॉर्टेंट है, राइट? तो ताले को ये थोड़ी ना पता है कि असली चाबी कौन सी है या फिर नकली चाबी कौन सी है. In the same way, when these antibodies, they mimic like a TSH hormone, they come and bind to the TSH receptor, they confuse the TSH receptor, they fool the TSH receptor, making them think that probably TSH hormone has present. Now because of this excessive stimulation, of the thyroid follicles, now this follicles are going to release excessive amount of T3 and T4. They're going to release excessive amount of T3 and T4. So when the secretion of T3, T4 is going to release or become more in the body, it will now result in hyperthyroid status. This is what we call it as the hyperthyroid status. Now this excessive stimulation is now causing the T3, T4 to release more, and that excessive release of T3, T4 is now resulting in hyperthyroid status. Until this point it is fine. We also know, because TSH hormone, as we have discussed in the physiology, it has two basic functions. One is to stimulate the thyroid follicles. Second, when it is in excess form, it is going to promote the growth also. Our follicular cells or our thyroid follicles do not know whether it is the hormone or the antibody, because they respond similar. Now because these antibodies mimic like hormone, they are causing overstimulation of the thyroid follicle, and that overstimulation of the thyroid follicle that overstimulation of the thyroid follicle will promote growth, and because of that growth, so initially there is excessive release of secretions, and as the growth continues to happen, it is now going to cause over proliferation. Now this over proliferation will result in hyperplasia, and this hyperplasia is under the influence of these antibodies. Now because there is hyperplasia, this hyperplasia of the thyroid follicles, this hyperplasia of the thyroid follicles will occur in all the follicles, no, because it is going to occur in all the follicles, because these antibodies are not going to be selective. They'll go to every single follicle which has a TSH receptor. It will go and bind to those TSH receptor. When it binds to those TSH receptor, they're getting that excessive amount of stimulus, and that excessive amount of stimulus is making them proliferate. Now once all the follicles are going to proliferate, what is going to happen? The gland is going to enlarge, and this is going to be in a diffuse form. Hence it is going to be a diffuse enlarged thyroid gland. It is going to be a diffuse enlarged thyroid gland will be formed. So initially the patient had the presentation of hyperthyroidism, and slowly the gland will also start to enlarge under the influence of TSH. Now you have two things. What are the two things? You have hyperthyroid status and the enlarged thyroid gland. So that is what we call it as diffuse toxic goiter. You see diffuse enlargement of the gland with hyperthyroid status, hence the name is diffuse toxic goiter. Did you all understand this concept? So why Graves' disease patient is having both enlargement of the thyroid gland, at the same time there is excessive amount of T3, T4 release. So hence resulting in hyperthyroid status. Clear? Now, if you have understood this basic concept, remember Graves' disease is associated. The Graves' disease is associated with the HLA component. It is associated with HLA-B8 and HLA-DR3. It is going to be associated with HLA-B8 and HLA-DR3. This is something that we have to remember. Now, how does a patient of Graves' disease present to you? So when you talk about the clinical presentation of the Graves' disease, the usual age of presentation, because it is an autoimmune disorder, it will be seen in a relatively younger age group. As I told you, all these disorders of thyroid are more common, especially the goiterous disorders are more common in female when compared to male, right? So how would these present to you? Now the Graves' disease have two different sorts of manifestation. One which is going to be related to thyroid gland, and one which is not related to thyroid gland. So we will discuss about both. So we talk about the thyroid manifestation. We will talk about the thyroid manifestation and the extra thyroid manifestation. And the extra thyroid manifestation. So we'll talk about both. So we'll discuss about what are the thyroid manifestation, what are the extra thyroid manifestation. Now in the thyroid manifestation, we will say the patient is having primary thyrotoxicosis. Now what is the basic objective of primary thyrotoxicosis? In a patient of primary thyrotoxicosis, there will be signs and symptoms of toxicosis. The signs and toxicosis will arrive first. It is then followed by thyroid swelling. It will then followed by the thyroid swelling, right? So the basic objective of primary thyrotoxicosis, here you will see the patient will have initially presentation of symptoms of toxicosis, and later on the swelling is going to come. The opposite will be seen in secondary thyrotoxicosis. You will have swelling which is present and then converts into toxicosis. Here it is ulta. You will have first symptoms of toxicosis and then the swelling will appear. Now when the swelling will appear, what it is going to be? It is going to be present to you as a midline neck swelling. It is going to be a midline neck swelling. This swelling will remain painless. It is going to gradually increase in size. this is going to move upwards with deglutination. This is going to move upwards with deglutination. These are the symptoms that you will see in the thyroid. Plus, more importantly, there will be signs and symptoms. It will be associated with signs and symptoms of hyperthyroidism. So you have a separate video on how to differentiate between the features suggestive of both hypo and hyperthyroidism. I have recorded that video separately. You can go and have a look at it. For now, you remember there'll be symptoms of hyperthyroidism also, but in the thyroid part, or from the thyroid's objective, you will see all these presentations. There will be swelling, it will be painless, gradually increasing in size, moves upwards with deglutination. It is going to have a hyperthyroid status. Now, when you examine these patients, right? So on examination, especially on Graves, what are the examination findings? Number one, it is going to have a smooth surface because it is going to be a uniform enlargement. It is going to, when you talk about the entire component, because there will be increased vascularity of the gland. Graves' disease associated with increased vascularity of the gland. It is associated with the increased vascularity of the gland. Now, because of increased vascularity of the gland, you will notice that there will be presence of bruit at the superior pole of the thyroid gland. At the superior pole of the thyroid gland. It will be associated with all the features of hyperthyroidism, but you will have more of CNS symptoms as well. So CNS is going to be a predominant component. You will see it will be associated with fine tremors. They are associated with the fine tremors, and there will be brisk deep tendon reflex. There will be brisk deep tendon reflexes as well. So it is going to be having smooth surface, increased vascularity, associated CNS symptoms. It will have fine tremors and a brisk deep tendon reflux. These are the findings that you will see in a patient of Graves' disease, but all these goes in favor of the thyroid manifestation. Now we talk about the extra thyroid manifestation. In the extra thyroid manifestation, number one, you have something called as the Graves' ophthalmopathy. You have something called as the Graves' ophthalmopathy, which is also called as eggs of Thalmos. This is also called as eggs of Thalmos, right? So what is this eggs of Thalmos that is going to happen? Now you take this as the representation of the orbit of the eye. The orbit of the eye is a bony cavity, right? Now the maximum capacity of the orbit of the eye is only 30 cc. Within this orbit of the eye, you will notice that the eyeball is being placed. So this is the eyeball that is present here. Now this eyeball will be anchored by different muscles. You have the superior rectus muscle, you have the inferior rectus, you have the medial rectus, you have the superior oblique as well as the inferior oblique. There are a lot of ocular muscles which are going to be present, right? There are going to be a lot of ocular muscles which are going to be present here. Now, these antibodies, so this is your superior rectus, this is your superior oblique, this is your medial rectus. Let's say this happens to be the inferior oblique, this is going to be the inferior rectus muscle. So these are all the ocular muscles which are present across here. Now these antibodies which are formed, these antibodies sometimes they get misdirected and they go and attack. So all these antibodies which are formed, the LATs antibodies. These LATs antibodies sometimes they get misdirected, and when they get misdirected, they go and attack these ocular muscles. Now when they attack these ocular muscles, they will cause inflammation of the ocular muscles. Inflammation of the ocular muscles will result in edema, and you will see all this edema is going to settle behind. It is going to settle behind the eye. So there's a retroorbital edema is going to occur. Now because the posterior surface is made up of a bony cavity, this is not going to budge. So all the accumulated fluid will exert pressure onto the eyeball. So hence the eyeball is now forced to pop out of the ocular cavity. This popping of the eyeball is what we call it as eggs of thalamus. So I'll repeat again, the Graves' ophthalmopathy, where you have a patient who's having an exophthalmos. That exophthalmos is because these antibodies, they get misdirected and go attack the ocular muscles. When they attack the ocular muscle, they'll cause retroorbital edema, and that retroorbital edema will push the eyeball, and pushing of the eyeball will result in exophthalmos. So these antibodies basically attack the ocular muscles. They'll ask you which ocular muscles are usually affected. It is going to be the inferior rectus, followed by medial rectus, followed by superior oblique, followed by lateral rectus. So this is the sequence in which you have to remember that the most common ocular muscle to be involved is going to be inferior rectus, followed by medial rectus, followed by superior oblique, followed by lateral rectus group of muscles. So this is going to be a Graves' ophthalmopathy. This is going to be a Graves' ophthalmopathy, right? Apart from Graves' ophthalmopathy, this is also going to have another extrathyroid manifestation, that is going to be thyroid acropathy. There's going to be thyroid acropathy. So when you say thyroid acropathy, it is basically formation. There is formation of new bones. There is formation of new bones in the metacarpals. Formation of new bones in the metacarpals. Right. So this is because of excessive calcium deposit. That is your thyroid acropathy. Now it is also associated with skin changes. That is going to be called as the dermopathy. It will be associated with the skin changes. That is going to be the dermopathy. And another extrathyroid manifestation is associated with gynecomastia. Is going to be associated with gynecomastia. So what are the extrathyroid manifestations that you have? There's going to be Graves' ophthalmopathy, there is thyroid acropathy, there's dermopathy, as well as gynecomastia. Okay. So these are the thyroid and the extra thyroid manifestations. Thyroid and the extra thyroid manifestations. Clear? So this is our patient of Graves' disease is going to present down to us, right? Now, in detail, we'll talk about the features of hyperthyroidism, which we have already done so before. But for now, you have to understand that this is our patient of Graves' disease if presence is going to be in our context. So we'll try to move this a bit this side so we have enough space. So this is about, guys, hold on for a second.